Welcome to this explainer. Today we're going to completely unpack cyclophosphamide. We'll be taking its pretty complex pharmacological profile and turning it into a super high-yield, highly testable study guide for your medical board exams. Let's get right into it. Here's our roadmap for today. We'll be covering 1. From warfare to the ward. 2. Mechanism of action. 3. Dosing and administration. 4. Toxicities and clinical management. And finally, 5. Modern alternatives and comparisons.
Section 1. From warfare to the ward. The dark origins of a lifesaver. It's actually wild how a tragic observation from a World War II chemical warfare accident directly inspired modern pharmacology. So back during World War I, sulfur mustard gas was used with absolutely devastating effects. But later during World War II, there was a military accident in Bari, Italy that exposed sailors to a related compound, nitrogen mustard. When autopsies were performed, they revealed profound bone marrow and lymphoid suppression. Scientists had a light bulb moment. If this compound systematically destroys healthy white blood cells, well, could it potentially be used to target malignant ones? This direct line of thinking led pharmacologist Norbert Brock and his team to synthesize cyclophosphamide in 1958, specifically designing it as a more stable, targeted prodrug.
This drug literally changed the game for rheumatology. It took near-certain terminal illnesses like severe vasculitis and lupus nephritis and turned them into manageable chronic conditions. In the 1980s, landmark NIH trials proved that high-dose IV pulse therapy combined with corticosteroids drastically reduced end-stage renal failure and lupus nephritis. And then there's the famous Fauci regimen, which combined daily oral cyclophosphamide with glucocorticoids. That protocol alone lowered the 1-year mortality rate of granulomatosis with polyangiitis, or GPA, from over 80% to an astonishing complete remission rate of greater than 90%. That is a massive paradigm shift.
Section 2. Mechanism of action. The hepatic bioactivation sequence.
Okay, highlight this next part in your brain because it is a massive board pearl. You need to memorize this exact activation pathway, specifically that it requires hepatic CYP450 to become active. You see, cyclophosphamide enters the bloodstream completely inactive. It must pass through the liver where CYP450 enzymes bioactivated into 4-hydroxycyclophosphamide. From there, it spontaneously cleaves into two very distinct molecules, phosphamide mustard and acrolein. Board examiners love testing you on its status as a prodrug requiring liver metabolism, so absolutely lock this sequence in.
So, phosphamide mustard. That's our active hero here. It functions as a non-phase-specific alkylating agent. It actively binds to DNA and creates cross-linkages specifically at the guanine N7 position. Commit that exact spot to memory. This mechanical block entirely prevents DNA replication, which ultimately triggers apoptosis, or programmed cell death, of those rapidly dividing B and T lymphocytes that are driving the severe autoimmune diseases.
But you know, every hero needs a villain, and here it is, acrolein. While phosphamide mustard does the actual healing, acrolein is just a highly toxic, unsaturated aldehyde with absolutely zero therapeutic benefit. None. Its main clinical significance is that it accumulates directly in the bladder, acting as a severe, damaging chemical irritant.
Section 3. Dosing and administration. Balancing efficacy and exposure.
How we actually give this drug matters tremendously. The modern clinical shift toward intravenous pulse dosing, like the Urolupus protocol, drastically lowers the cumulative exposure and toxicity compared to the traditional daily oral pill. The daily oral pill, yeah, it gives you continuous immunosuppression, but at the cost of a much higher cumulative lifetime dose, which really drives up toxicity. By contrast, giving 500 milligrams via IV every 2 weeks, like in the Urolupus trial, achieves similar remission rates, but with significantly less risk of bladder toxicity and infertility. The only real catch is that the patient actually has to come into the clinic for their infusions. Section 4. Toxicities and clinical management. Taming the double-edged sword.
All right, focus up, because the concepts we're covering next are incredibly high yield for your exams. If you see hemorrhagic cystitis on your boards, immediately link it to acrolein, and even more importantly, link it to the rescue agent mesna. Mesna is a sulfhydryl compound that literally binds to and detoxifies acrolein right there in the bladder. Combine that with aggressive hydration, and you're good. The other major toxicity to watch for is infertility. This happens because of direct gonadal damage to developing oocytes and sperm. Modern mitigation requires giving GnRH agonists, like leuprolide, to put the ovaries into a quiescent, protected state during therapy, alongside freezing eggs and sperm.
Furthermore, you absolutely must aggressively protect the patient from opportunistic infections. Because this drug causes bone marrow suppression, leading to leukopenia, you have to use prophylactic Bactrim to ward off pneumocystis jirovecii pneumonia. And lastly, you have to be super vigilant about secondary malignancies. Long-term exposure drastically increases the risk of later life bladder cancer and acute myeloid leukemia, or AML. The only real mitigation strategy here is strictly limiting the patient's cumulative lifetime dose. You have to watch that number like a hawk.
Section 5. Modern Alternatives and Comparisons. The Rheumatology Showdown.
These days, cyclophosphamide isn't always the automatic MVP. For ANCA-associated vasculitis, rituximab, which is a targeted anti-CD20 monoclonal antibody, has largely taken the crown as the first-line treatment. It offers similar efficacy to cyclophosphamide, but with vastly better fertility preservation and less cumulative toxicity. So, when do we still use cyclophosphamide? It's reserved as a potent rescue therapy for the most rapidly progressive life-threatening crises. Think severe renal failure or diffuse alveolar hemorrhage, situations where you need rapid, brute force immune suppression.
It's a very similar story with lupus nephritis. Mycophenolate mofetil, or MMF, is now the preferred initial therapy. Why? Because it completely eliminates the risk of gonadal toxicity, giving it a much superior safety profile. But once again, cyclophosphamide remains totally vital as a heavy-hitting backup. It's deployed for high-risk nephritis, severe neuropsychiatric lupus, or in clinical cases that prove completely refractory to MMF.
Okay, let's do a rapid-fire recap of these absolute must-know board pearls before we wrap up this explainer. 1. Cyclophosphamide is an alkylating agent that requires activation by hepatic CYP450. 2. Its toxic metabolite acrolein causes hemorrhagic cystitis. 3. You prevent this specific bladder toxicity with aggressive hydration and IV mesna. 4. It causes permanent dose-dependent infertility, meaning you must protect patients with GnRH agonists. 5. It is heavily associated with later-life bladder cancer and AML. And 6. Today, it primarily acts as a highly potent rescue therapy for severe ANCA vasculitis and lupus nephritis when gentler options fail.
Which leaves us with kind of a philosophical question to end on. As medicine continues to evolve and we develop safer, highly targeted biologics, will we eventually outgrow this potent pharmacological double-edged sword entirely? Or is a definitive, highly cost-effective rescue agent always going to be necessary for those times when our gentler options just fail to work quickly enough? It's a profound clinical dilemma to consider as you study. Thanks for joining me on this explainer, and best of luck on your board exams.